My name is Kesava Ramakrishnan. I'm a pediatric intensivist. Welcome to this video on ECMO patient selection general principles. ECMO is a temporary supportive therapy. Most patients are on ECMO for a few days to a few weeks. This is especially true of veno-arterial ECMO. I have heard of an occasional patient on VV ECMO being treated for a few hundred days. However, it would be extremely difficult to carry on VA ECMO for any longer than a few weeks. It is also important to recognize that ECMO carries a very high risk of complications. The most dreaded complication is neurological injury from air embolism or stroke or intracranial hemorrhage. There is also a significant risk of life-threatening bleeding, especially if you have cannulated the patient through sternotomy, in other words, central cannulation. With peripheral cannulation, there is a significant risk of limb ischemia, which could lead to necrosis and may require amputation. It is a real challenge for healthcare teams to keep a patient on ECMO for even a few weeks. I have worked in units where many times we have closed the unit for other admissions because we have two patients on ECMO. To manage an ECMO patient, you need a whole team, including surgeon, perfusionist, ECMO specialist, bedside nurses, ECMO physicians, and so on. This may divert the resources that you would be using for other patients in the hospital to this specific patient, which may be a concern to the healthcare team, especially when looking from the equity of distribution. Also, if the family has to bear the cost, they could be left with a huge financial burden. As ECMO carries significant risks, we need to be very careful with patient selection to make sure that the benefits of the therapy are more than the risks that we expose the patient to. The Extracorporeal Life Support Organization, based on expert opinion, recommends that we should consider ECMO when the predicted mortality is more than 50%. What they suggest is that patients with predicted mortality or mortality risk less than 50% may not derive huge benefit from use of ECMO. They recommend that ECMO would be definitely of benefit if the predicted mortality is more than 80%. Although we are getting better at defining mortality risk, this is not straightforward for most patients, especially pediatric patients. There is a lack of randomized trial data to guide patient selection. The adult ECMO physicians have started gathering this data. They are likely to have more robust patient selection criteria supported by experimental data in near future. So how can we use ECMO? If the patient has a reversible condition, ECMO can be used as a bridge to recovery. If the patient has access to transplantation and is on a transplant list and has end-stage cardiac or respiratory failure, ECMO can be used as a bridge to transplantation. Ventricular assist devices are gradually improving in design and are gradually becoming destination therapy and an alternative to transplantation. As a result, you could use ECMO as a bridge to destination therapy such as ventricular assist device, but this is only for patients with cardiac failure. This is not a consideration in patients with respiratory failure on VV ECMO. Occasionally, the prognosis is not clear and you may use ECMO as a bridge to decision. For example, when you are in a situation of ECPR or ECMO for cardiopulmonary arrest, you can use the ECMO to bridge to decision, which means you can support the end organ perfusion with ECMO while you're waiting to clarify the prognosis for the neurological injury because of the nature of ECMO, and many times ECMO is instituted as an emergency. It is not always possible to get your judgment right and put only the right patients on ECMO. You can facilitate the patient selection by having a discussion about potential patients within MDT and making a decision on whether you should offer ECMO or not. Frequently, you end up with a patient who is on ECMO and the prognosis has become clear now that the organ is unlikely to recover, but there are no options for transplantation or destination therapy. This situation has been labeled bridge to nowhere. This may be unavoidable. However, if you have communicated well with the family and adopted a shared decision model with the patient or the surrogate consent giver, you may be able to convert this situation into bridge to somewhere with an objective to provide meaningful goals such as a little bit of extra time to spend with family and so on. Key words in this process are collaborative, decisions taken together with the patient or the family using best scientific evidence and taking patients' values and preferences into account. Key to not ending up in this situation is communication. It is important to set clear expectations that ECMO is temporary and supportive. It is also important to set timelines with the family on when you would assess the benefits and burdens again. One thing that clinicians can improve is eliciting patient values. It is worth asking what would the patient have wanted. It is also important not to be paternalistic and support the family decisions, which may be contradictory to physicians, as long as it is not against the best interest of the patient. It is also important to keep reassuring the family that everything possible is being done. Thank you.